Hello, everyone, and welcome to today's HealthTree for DLBCL webinar. My name is Kat, and I am the Education Manager for Lymphoma at HealthTree. I'm very grateful to have each of you here today and for your support in building this community. We'll start with a brief meeting tutorial for those who are new to the platform. We would love for you to keep your cameras on if you feel comfortable doing so. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see a microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. If you are not comfortable being recorded, you are not required to keep your camera on. Your microphone should currently be off and will be kept off by our team throughout the presentation. During the group discussion, you are welcome to unmute yourself once called upon. If you have any questions or comments for us or for our speaker throughout the presentation, please click on the chat icon and type them in the box. If you're using a mobile device or tablet, click the three dots icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you are using a laptop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you are using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. Before we get started, I'd like to thank our sponsors Regeneron and Bristol Myers Squibb, who made this event possible. Our topic for today is CAR T therapy advances in large B-cell lymphoma. Here is the agenda for today. I will introduce our speaker, Dr. David Miklos, and then he will spend the next 30 minutes or so giving us his presentation. After the presentation, we will open it up for your questions and comments. Now I'll take a moment to introduce Dr. David Miklos. Dr. Miklos is the Chief of Standard BMT and Cell Therapy Program, which provides 750 cancer cell therapies annually. Their BMT CT research fosters the development of both laboratory immunologists and clinical translational researchers. Their allo-HCT research is optimizing graft content of HSC, conventional T lymphocyte, and regulatory T cell content in order to cure blood cancers via beneficial graft versus tumor immunity while reducing graft versus host risk. Their CAR T research provides the most direct targeting of cancer and is dramatically improving leukemia and lymphoma with no graft versus host disease risk. Their goal is to combine graft-engineered allogenic HCT with CAR T benefits. And now I will turn the time over to Dr. Miklos.
Thank you, Catherine, and thank you to HealthTree for having me as your guest today. I will start with a prepared presentation that I think is a very general talk to patients and families, and then we'll stay on to answer questions. And again, I really welcome this opportunity to outreach to patients directly, and thank HealthTree for this type of patient advocacy. So let me begin with the presentation. Catherine, are we okay? I think we're okay. So again, my title today is chimeric antigen receptor therapy, focusing on lymphoma and especially the second-line therapies and randomized trials. I don't hold individual stocks in the biotech industry. I don't have equity in any companies. I work alongside and collaboratively with many pharmaceutical companies, and Stanford alone does a lot of research and manufacturing CAR Ts ourselves. So while I have a full board of conflict, I don't feel conflicted. The story of cell therapy really begins with hematopoietic stem cell transplantation. And in this, the hematopoietic stem cells here on the far left are able to pluripotently turn into every blood element that you're familiar with: the red cells, the white cells, the platelets, and in those white cells, the granulocytes, the lymphocytes, and more importantly, the B cells and the T cells. And so many of you have heard about bone marrow transplant. It's kind of an anachronistic term at this point, as cell therapies have advanced into many other specialized treatments, but bone marrow transplant is where we began, and putting somebody else's immune system and hematopoietic stem cells. So putting their stem cells plus their pre-educated B and T lymphocytes into the body of a recipient who may have cancer, lymphoma, myeloma, immunologically destroying their blood system, replacing it with the healthy donor system, and growing back a normal blood system has been the only cell therapy available early on from 1968 forward. Now, the problems with this are that if you are using your own stem cells, an autologous stem cell transplant, or better called hematopoietic stem cell transplantation, um, or how about this one? High dose chemotherapy with stem cell rescue. The problem there is you give a lot of chemotherapy at high levels and it can damage the heart, the lungs, the tissues of the body. So toxicity, and then you have to rebuild the immune system. So infectious complications. And when you put somebody else's system in there, you again have the conditioning toxicities, the infectious toxicities, but you have the donor's immune system that may not only eliminate the blood system, but also attack the normal tissues of the body. This is something we call graft versus host disease. And the most common tissues to be damaged are the skin with rash, the GI tract with diarrhea, or liver. And so while I am an allogeneic, proud allogeneic bone marrow transplant physician, and it has carried the field for many patients who have leukemias and myeloid disorders, we're excited to be able to eliminate the risks of graft versus host disease by focusing on T cells of the patients themselves. Now, Steve Rosenberg of the National Cancer Institute, he pioneered this back in the 80s. He was using therapies where he harvested T lymphocytes from the tumors, especially melanoma or renal cell carcinomas, and then expanded them in the laboratory, put them back into the body of the patients, and then those T cells themselves cured the patients. This is very important that we acknowledge Dr. Rosenberg's contribution. This year, a company, Iovance, had the first FDA-approved therapy for tumor-infiltrating lymphocytes, or what's called TILs. And these TILs therapy are now available for patients in third-line melanoma treatment. The T cell is powerful, it's specific, it provides memory, and it could be a universal treatment for many patients going forward. This was the 1980s, and I'll remind you that we're 40 years since. So in the years of the 90s and early 2000 to maybe 2010, the CAR-T field, which is the chimeric antigen receptor therapy field, was developed through optimizing the constructs that were going to, on the top surface, bind to antigens on tumor cells themselves. And these look like antibody motifs because most of them were taken from established antibody binders. And on the inside of that blue membrane are the activators of the T cells, the zeta chain. And then what you see moving left to right is the addition of what I call motors, but others call co-stimulatory devices. Those are the molecules CD28, 4-1BB, or other co-stimulatory molecules. Dr. Eshar is well deserved for the development of the concept and moving the therapy from the mouse into the first of the clinical trials of 2010 really required a lot of preclinical work done in cell culture or mouse model systems. And this is a very just simple way to summarize the contributions of thousands of people. Now, the question once you develop a CAR T cell is what will you target? And here I show a schematic on the left of the common lymphoid progenitor, then moving to the right as a plasma cell. These are normal blood development patterns in all of our bone marrows where we make B lymphocytes. Those B lymphocytes interact with antigens, go to lymph nodes, interact with T cells, and ultimately make antibody secreting plasma cells. I make this in a long linear shape so that we could try to emphasize that there's the expression on the surface of the B cells of molecules well known to you, CD20, the target of rituximab, CD19, the target of most of the first generation CAR T cells. These are molecules that are not expressed on other types of cells in the body. They're not on your brain, they're not in your skin, they're not in your lungs. And so when we have these expressed on our B cells alone, then an agent like rituximab or a CAR T cell targeting CD19 can eliminate the cancerous B lymphocyte, but also the normal B lymphocyte at the same time, which has immune reconstitution effects. Still, if I now stack the same progression in a more vertical way and discuss how cancers are developing in relation to normal B cell ontogeny. And so the earliest stages that can be blocked result in acute lymphoblastic leukemia. Later stages result in CLL or Burkitt's lymphoma, mantle cell lymphoma, follicular lymphoma, diffuse large cell lymphoma, Waldenstrom's, and ultimately multiple myeloma. So CD19, as you see, is expressed from the acute lymphoblastic leukemias all the way through the late Waldenstrom patients and provided a target that would be beneficial to hundreds of thousands of patients when a effective therapy is developed. The same therapy can be used in ALL, CLL, mantle cell lymphoma, large cell lymphoma. There are some other targeting opportunities there, and those are being developed concurrently. Nonetheless, there are three commercial FDA-approved CD19 targeting CAR T cell constructs. And this slide shows the schematic that the binding, again, on the top of the membrane that recognizes the lymphoma-specific, B-cell-specific protein called CD19 is the same in all three of these commercial products. It is derived from something called FMC 63, and it binds to CD19, whether it was developed at the National Cancer Institute, University of Pennsylvania, the Fred Hutch Cancer Research Center, and whether it's ultimately turned into a company, Kite Gilead, Novartis, or Bristol Myers Squibb. These are the agents that are now FDA approved in third line and some of them in second line therapy. Stepping back again, as we put the CAR T cells into the patient, it requires that the patient's T cells first be collected through a process called apheresis, genetically modified in a isolated cell laboratory. Much of that's being done commercially, but it is also being done at leading centers across the country like Stanford, University of Pennsylvania, Fred Hutch, where these therapies are being developed. Then the therapies are frozen, usually, brought to the patients at bedside, thawed, and infused. And a fixed dose, a number of cells are infused, anywhere from 500,000 to 100 million cells. And then in the body, they expand as shown on this graph. So when, for example, Lysocell or Axicell, the agents that are targeting CD19, are infused roughly 2 million cells per recipient weight kg, or about 100 million cells are infused. And on this schematic diagram, you see that over the next 7 days, they expand. They're doubling every 7 to 14 hours. Think about that, 2, 4, 8, 16. You put in 2 million and soon you have 2 billion cells circulating, and they can account for upwards of 10 to 50% of the circulating T cells, yet alone the ones that actually get into the tumor and kill the cancer. So this expansion is associated with a toxicity that's well known to the CAR T field called cytokine release syndrome. I like to call that the flu syndrome. When you had your last infection, you had a sore throat, sure, or you had diarrhea, but you also had fever, achiness, lightheadedness, problems with being alert. Maybe you even got confused and had the neurological consequences. So in CAR T, we first see fever, sometimes hypotension, low blood pressure, or requiring oxygen. But then if this continues, patients could have low blood pressure requiring blood pressure medicines. Now, the good news is we've developed many ways to temper the expansion of the CAR T cells so that that doesn't become a major toxic problem. And the early use of tocilizumab and steroids has managed this in all centers. Neurological consequences are much less common than they used to be. We have Carl June of University of Pennsylvania to thank for this here shown, and a good friend, wonderful colleague, and a pioneer in the field of CAR T. Carl June treated the first of the leukemia children named Emily, and she's well known to the community. Emily Whitehead was 5 years old when she was treated with acute lymphoblastic leukemia by Steve Grupp and Carl June at University of Pennsylvania. And she had these fever. This is just a fever curve. And then Carl June made the observation, being very familiar with juvenile rheumatoid arthritis, that this is likely due to IL-6. They measured the levels, they were very high, and they determined that if they gave an antibody against IL-6, they could block this. Now, this is Emily. 9 years later, she's actually now a freshman at the University of Pennsylvania, 12 years out, cancer-free, and a wonderful young woman. The use of tocilizumab and other immune modulators has become part and parcel of the successful treatments of patients using cell therapies such as CAR T. So in summary, the development over the last 20 years of CAR T has resulted in benefits that chemotherapy never offered you. That is, these are living therapies. They expand and proliferate to match the tumor burden to meet the patient's need. They localize to the lymphoma, to the multiple myeloma, because these T cells circulate in those spaces. They take advantage of cytotoxic T cell killing, which our evolution over 10,000 generations has optimized in our bodies. And that's how we control our infections, our influenzas, our COVIDs. And here we are able to hijack our own cytotoxic T cells to attack the cancer. They persist and they provide us surveillance, and they've really dramatically changed the landscape of the treatment of lymphoma, myeloma, acute leukemia. Again, this is the summary slide, 3 commercial agents that are available, and they all have a binder, a motor, and they have a T cell activator. I'll point out that the axi-cell on the left uses a CD28, which may be the more robust motor with more rapid acceleration of T cell expansion. And the other 2 agents, Tisa-cell and Lysa-cell, use the 4-1BB, which have a little bit slower acceleration, but a longer persistence. And this is still being determined which diseases are going to be best treated with which of these different CAR T cells. So this, I had the pleasure of participating in the ZUMA-1 study, which tested for axi-cell in 2016. 100 patients received this therapy. The patients, as you see on the top, have progression, usually 3 or 6 months. And after 6 months, the plateau suggests that patients are being cured. And in comparison to therapies available for relapse refractory patients who had progression after 3 lines of therapy previously, shown on the Scholar curve, this was a significant advancement. Historically, only about 12% of patients were surviving at a year, and here the survival rates are greater than 40% at 5 years. At Stanford, where we've used these same therapies, optimized patient selection, moved patients into treatment quickly, and have improved our toxicity management, we've seen even greater outcomes. You notice that the 1-year progression-free survival in 2022 at our center was almost 61%, and overall survival was 75%. And this shows you how the same therapy, once physicians, nurses, and the teams learn how to use it more effectively, can become a much more effective therapy. Historically, in second-line patients who had large cell lymphoma, where they initially are being treated with R-CHOP or induction chemotherapy, now you may be having the addition of polatuzumab or some other agents to the R-CHOP. But nonetheless, about 80% of the patients will achieve complete remission. That means they can't see the cancer after 6 cycles of induction. However, 40% will either be refractory or relapsing. And so again, 4 out of 10 patients are going to need another therapy. Historically, we used to rely on the high-dose chemotherapy and stem cell transplant, and those patients would receive platinum-based chemotherapy, and if they were responsive to this type of chemotherapy, they would go on to high-dose chemotherapy with stem cell rescue. But the numbers of patients who were benefiting from this was relatively limited, mostly because of the 50 transplant-eligible patients, only about 40% or a third of the patients would be chemo-responsive and able to move forward with the auto transplant. So we needed to do better. The development of CAR T cells, which again, were first treated in patients in 3rd line, were brought to the 2nd line through a randomized controlled trial. And this was a comparison of auto transplant versus the treatment with immediate CAR-19 therapy. Here I show the development of Zuma 7. This was the axi-cell, but there's a very similar randomized trial that was done with liso-cel as well as tisa-cel. And they focused on patients who had relapsed within 1 year of induction or who were refractory to the chemotherapy in the first place. Those patients were then asked to participate in a clinical trial willing to be randomized between either additional standard of care chemotherapy with an intent to go to auto transplant or immediately receive the CAR T cell. And the scope of comparing these three trials is beyond what I want to focus on today. But both the Zuma 7 and the Transform studies of axi-cell and liso-cel, respectively, were very successful. They were very similarly designed, and they both showed benefit of the CAR T cell over auto transplant. They enrolled mostly patients who had refractory disease. That is, what they still had measurable cancer on their PET scan at the end of the induction CHOP chemotherapy. And they had equal numbers of patients with high-grade disease or MYC rearrangements. And the results were not subtle. Here we show the Zuma 7 axi-cell results, where 46% of the patients remained progression-free with axi-cell versus only 27 receiving chemo with an intent to go to transplant or standard of care. And likewise, liso-cel in the Transform study showed 58.2% remaining progression-free with liso-cel versus 28% with standard of care. These studies have gone forward, longer outcomes, and last year, ASCO, this time last year, we presented the results of the 5-year mature outcomes of Zuma 7 and showed that there was an overall survival benefit, even though many of the patients crossed over to receive third-line CAR T cells. And so this, again, is the work of the Zuma 7 investigators with 5 years of mature follow-up, overall survival on this graph showing that at median follow-up of 47.2, 54.6% of the patients are alive who received the axi-cell versus 46% who had the randomization to standard of care with intent to go to auto transplant. And again, 57% of those patients received CAR T off the trial in an attempt to, again, salvage the patients who needed to manage their cancer. Not only was the therapy more effective, but the patient-reported outcomes favored the treatment with Zuma 7 axi-cell. There were benefits of, as you can imagine, when patients are going through the auto transplant, they're not as happy with the chemotherapy. But even in the long term, the CAR T cells showed benefits. People ask me all the time, what is the persistence of the CAR? And here's the data from Zuma 7 showing in blue how the CAR T cells peak 7 days after infusion and then over the next year are coming down, but still detectable all the way out through 2 years in this analysis. And you see that there are very wide error bars here, meaning that there's a very heterogeneous removal of the CAR T cells. Likewise, CAR T cells are eating healthy B cells, not just the lymphoma. And so one of the monitoring mechanisms for whether or not the CAR T cells are still killing is whether or not the B cells are able to recover. And so B cell recovery is occurring here on average around 12 months, but again, heterogeneously out through 24 months. And so this separation of the CAR diminution from the recovery of the immune system is one of the things that my lab spends a lot of time trying to understand better. What do we focus on? Well, on the left, we think about CAR T cells, axi-cell, liso-cell, and we look at CD19 expression. We look at what T cell would be the most effective cell to make the chimeric antigen receptor molecules in. And we look at the metabolisms of these cells. We look at the microenvironment of the tumors and try to understand which is more predictive for benefit. And in the old situation where we're using chemotherapy and high-dose chemotherapy, we're much more focused on how much tumor was present, what type of cancer it was, and whether or not the patient could tolerate those types of cancer. So very different therapies. And we would imagine that based on these different toxicities, the CAR T could be used in much older age group, and that is definitely true. We would not offer high dose chemotherapy or auto transplant in patients beyond the ages of 70. And one could argue now that cards available, we should go even lower. But again, I know of patients, I've treated patients 86 years old with CAR T cells, and I have colleagues who've treated 91-year-olds. So my main conclusion for today is that CAR T cell therapy is available. Axi-cell, Lysa-cell is approved for second-line treatment. These therapies are shown to be not only having progression-free benefit, but overall survival benefit. Axi-cell's study was large enough to show an 8.6% absolute benefit at 4 years, which is a reduction of death by 27.4%. The overall survival benefit was seen across all different types of patients, didn't differ by age or by disease type. And this was something which, again, was the first of the randomized controlled trials in lymphoma to show survival benefit in 30 years. The Lysa-cell has similar benefits and is FDA approved in second line along with Axi-cell. Tisa-cell has not achieved that recognition yet. And this second line therapy offers patients earlier treatment benefits, less toxicity, and improved overall survival. So I'm sure there'll be questions around this. Now, as I said to you, my laboratory is trying to understand how to make the therapy of targeted T cell therapy more effective. And as you consider the patient undergoing apheresis, collecting their T cells, going through viral inductions, and then having the infusion back into the patients, there's a number of ways that you could have the treatment fail. A lot of this is based on what the actual tumor biology is. Not everybody has the same exact type of large cell or follicular or other types of lymphoma. The tumor microenvironments are very important. The expression of the antigen on the surface that the CAR is targeting. It's easier to target more antigen than less antigen. And if a patient has a lot of tumor, it's more difficult to cure than if a patient has been prepped and has lower disease burden going into the therapy. We're still very interested in what's the most effective T cell to work with in this CAR T therapy. We want to improve manufacturing. We want to have a more successful transduction, a shorter time for manufacturing, and a greater ability for these cells to function in body. And so there's a lot to be learned. A couple of the science talks, if we look in the lymph nodes themselves, the simplest predictor of who's going to do better is that the patient's tumor has lots of T cells infiltrating at the time of diagnosis, and they don't have inhibitory molecules called T regulatory cells in the tumor themselves. This is a young woman that I treated back in 2018, and the black on the PET scan is a marker of the disease. You can see that after the Axi-cell therapy, all of the lesions are gone. This is a normal looking PET scan where the uptake of radioactive sugar is going to the brain, the kidneys, and the bladder. But within 30 days, she's had recurrence at 3 sites of the disease. And when we biopsied the cervical lesion here, whereas she had high expression of CD19 before the CAR T cell therapy shown by the brown stain, now afterwards at day 60, you can see the absence of the brown stain for CD19, suggesting that the cells that came back no longer expressed the target of the CAR T cell. That in this bulk of tumors, some of the areas had cells that had mutated the expression of CD19, and those are the ones that escaped the CAR therapy and came back. Now, this is not an uncommon problem. Here is the analysis of the first 50 patients we treated at Stanford, and 17 had progression, and we show you the expression of their tumor antigens by immunohistochemistry before and after. And so on the far right, you see 6 patients where there's really no detection of CAR19. Then in the middle, you see low expression of CAR19 here shown in the green, yellow, and teal. And then on the left, you see patients who still have good expression but had progression. So there must be other reasons why patients have tumor progression. And our lab has been trying to really understand this even better. These are 2 patients that have flow cytometry being done. This is on their aspirate of their tumors. And the blue is the B cell that is expressing the amount of CD19. And The shift to the right means that there's a lot of CD19 being expressed, and it's a very tight band. On the lower panel, you see that the shift has gone left. There's less CD19, and there's a lot of cells in the blue that overlap with the red T cells. Now, these red T cells are negative for CD19, of course. Those are our negative controls, and this shows there's a lot of cells in this patient that don't have the target for CD19, and we would predict that these are the cells that will grow out later. And so we've developed assays to quantify this and be able to measure the number of molecules per cell and try to make this into more of science and try to make this more quantifiable. And it, in fact, is being validated by myself and other colleagues. And again, same phenomena, now looking at 50 patients, 60 patients, where the expression of CD19 in bulk before the treatment with CAR-19 is a tight, normal, high CD19 expression curve. And then afterwards is a big shoulder over here of CD19 negative, and that occurs in patients who have progression of their cancer. So the loss of CD19 or the current strategy of targeting only one tumor antigen seems to be a common reason that patients have treatment failure. So we should target two, CD19 and, well, as you talked about already, CD20 or CD22. You could build two separate CAR cells, or you could build one cell that targets 19 and 20 or 22, or you could build a mousetrap that has an ability to bind within the same polypeptide, CD19 and CD20 or CD22. And these are strategies that are being pursued by many, many companies. Our Stanford organization, with the leadership of Crystal Mackel back in 2017, did a first-in-man investigative study where we tried to build a loop CAR. And here, the green binds CD19 and the purple binds CD22. This is a target that would be both good for lymphoma as well as for acute lymphoblastic leukemia. And we expected that we would avoid antigen loss by doing this type of therapy, but we didn't. And so when we looked at patients who were progressing, we noted that they still had CD19 antigen loss. These numbers are very low. We expect them to be up in the thousands in order to be adequately killed by CARs, but the persistence of the CAR and the loss of the expression of CD19 while maintaining CD20, said that the proximal 19 was working well and the 22 was not. So we built a 22 by itself, and this 22 by itself was tested against molecules of CD22 in comparison to the loop CAR. And this graph shows, especially on the low right, that there's a lot more IL-2 and interferon gamma and cell killing when we use the CAR-22 in isolation compared to our bispecific CAR-1922. And we went forward with a second clinical trial using the CAR-22 in patients who had already received CAR-19 and their tumors progressed on average 3 months after the CAR-19 therapy. And this has been a huge success because in this study of 40 patients, we have in the 29 receiving the recommended dose level going forward, a 53% complete response rate. These were patients who already received CAR-19 and now are getting the CAR-22. And 80% of the patients who achieved the complete response have not relapsed beyond 2 years. And so this is now in Lancet and coming forward. Stanford successful investigator-initiated trial, and this has moved on to a company, Cargo, and they're trying to repeat these results and obtain an FDA indication to, again, bring CAR-22 to the lymphoma patients. Here again, two other strategies besides sequential use of CARs would involve bicistronic expression from a single viral insertion, as Kite 363 study is doing, and this study is open at our institution, where we would put two molecules on the surface, one that's binding 19, one binding 20, and they're able to, again, work in harmony. And again, the other idea is to build the single polypeptide that binds to two different antigens on the same one molecule. Miltenyi is a company that is made a molecule like this, and I've been actively involved in this clinical trial, the Zamtocel. And these studies are ongoing, and I always encourage people to participate in clinical trials. Two antigens seems to make sense going forward. So today what I talked to you about is using CAR T cells in earlier lines of therapy, that the second line axi-cell lysis-cell is now standard of care. It's very important to be seen early before the tumor burden is large. and shortening manufacturing, having higher success in manufacturing is critical to the patient's benefit. Didn't talk too much about this, but LDH is a very good surrogate for tumor burden. And those of you with lower LDH have less tumor and less concern and higher opportunity to be cured by CAR T cells. We have done a lot of work where we've shown that there are inhibitor cells in the products that need to be removed, and companies are working on that, as is our individual academic centers. The tumor microenvironment, the increased activity in patients who have lots of T cell infiltrating and who have less of the inhibitory myelosuppressive cells or regulatory T cells. And as I say to you, multi-antigen targeting of CD19 2022 seems to be the most successful strategy in what I'll call generation 2 of CAR T cells that will benefit patients. In summary, again, patients who are intended to get transplant have frequently not received the benefit of high-dose chemotherapy because their tumors are not chemoresponsive. Second-line CAR-19 therapy with liso-cel and axi-cel is effective, and axi-cel offers an overall survival benefit. And the guidance of where to place these is to get patients into second-line CAR T cells. In those patients, it's important to be referred early, to have good collaboration between the referring doctors and the CAR T treatment centers. And then Dr. Miklos believes the predictors of long-term CAR T durable response are lower tumor burden, with LDH providing the best surrogate measurement, and rapid referral with short vein to vein, that is rapid manufacturing and getting the patient to treatment quickly. In addition to CRS and ICANS, or neurological toxicities, concerns for long-term infection and viral infection remains important. So I'll close with the honor, acknowledging my team at Stanford, and in particular at the bottom left, Crystal Mackel, who heads up pediatric and solid tumor CAR T cell therapy. And it really takes a lot of specialization to be able to build these therapies and to bring these treatments to patients. So with that, I stop, and I again thank you for the opportunity to speak today. It's my pleasure to be here at HealthTree, and Catherine, thank you for the invitation. Not
Thank
sure
you.
why my hand is up. Seems like I want my attention. Let me see if I can put my hand down. There you go. Sorry about that.
No problem. Thank you so much for that presentation. That was so helpful and very thorough. Now we will have the discussion part of today's event. Let me share that screen with you. Let's see. Okay. So now I will go into the question portion. I know we have a question in the chat. Let me see if I can find that question. So Megan wants to know that, do you anticipate in the future of creation of cellular therapies that you will have therapies that only target the cancerous B cells and not the healthy B cells, so you can avoid B cell aplasia as a long-term side effect?
No, I doubt that, Megan. But maybe there's a different strategy. So at Stanford, we have in acute lymphoblastic leukemia joined allogeneic transplantation with CAR T cell therapy in one maneuver. That is, we collect T cells from the histocompatible allogeneic donor and make a CAR. And then we collect the stem cells and we collect the T cells from the donor, and we bring the patient through allogeneic conditioning. And then we add back the CAR and the now healthy hematopoietic stem cell from the donor, and then grow back the cells. What if we go one step further and the allogeneic donors are now modified so that the CAR doesn't damage the hematopoietic stem cells that will grow back B cells, T cells, and neutrophils? What if we could take CAR to myeloid leukemia, AML and MDS, by removing, let's say, changing the epitopes, the recognition sites of the myeloid cells? Maybe you've heard these names before: CD33, CD34, FLT3. What if we could shield the donor stem cells from the effective CAR T cell, and then let the CAR T cells destroy all the AML, all the cancer, but at the same time, the allogeneic healthy donor cells grow back in the presence of the CAR T cell and are resistant to it, or shield technology. So those are the steps that are coming forward. It's not that we're going to be able to find a new antigen that is only on the tumor. That's the struggle that we have in solid tumor. We've been fortunate in B cells that we're able to use targets CD19, 2022, 79A, 79B, others as well, that are only on B cells, and that we can, as we've learned through the use of rituximab since 1995, patients can have brief periods of B cell aplasia with the recovery of the B cells afterwards. So I hope that answered the question. I don't anticipate that we will have a CAR that only sees the tumor. I do think that we will be using more clever strategies. And I believe that the hematopoietic stem cell and allogeneic transplantation will be very important in the future development. And as we use more effective targeted T cells in the allo transplant, we put in less of the GVHD risking T cells so that the patients have much less non-relapse mortality.
Thank you for that explanation. I'll ask some pre-submitted questions from patients, and in the meantime, if anyone has questions, you can put them in the chat box or raise your hand. So what is the general treatment regimen for CAR T therapy? Is it how many days is it? How long does it take? How does that regimen go?
Well, good question. I should have put a slide in like that. So it's a kind of three parts. The first step being educating the patient. Unfortunately, there's a lot of insurance authorization required for this. As you know, these treatments commercially require $500,000. And we need to move that as quickly as we can. The first step for the patient's treatment is to apheresis, that is, take the cells out of the blood, spin, separate the heavy nucleated T cells away from the platelets, the red cells. So collect the T cells, putting the blood back in and re-spinning, and this takes about 3 hours. It's a procedure that's done hundreds of times a week in most hospitals, apheresis, and here we're collecting your T cells. Those T cells then go to commercial centers where the genetic changes of the CAR is occurring in the population that will become your drug, your CAR T cell therapy. And it's a patient-specific therapy. It only works for you. You can't use those cells for somebody else. So you see the logistics of this are quite cumbersome. The cells are, shipped and then manufactured and then returned and kept in liquid nitrogen, and the integrity and the chain of custody must be maintained and then brought to you when you're ready. And you say, when you're ready, what do you mean? I thought I was ready. Well, we're still going to do a second step that is called lymphodepleting chemotherapy, giving doses of chemotherapy, cyclophosphamide and fludarabine being the most common, but there are others, cyclophosphamide and fludarabine, usually in the outpatient setting, relatively low doses compared to transplantation or CHOP. And again, about 3 hours in most centers done in the infusion centers on day -5, and then again on day -4, and again on day -3. Then you're off recovering on day -2, day -1. The nausea can be a problem, but these are doses that are less than what your CHOP chemotherapy has used. And then patients are either treated in the outpatient with the infusion or in the inpatient. That depends on what the perceived risk of the toxicity of cytokine release syndrome or neurological toxicity is. Those are center-specific decisions and product-specific decisions. If you were to, at my center, receive Axicell, the Kite manufactured product, you would receive that in the inpatient setting. If you were receiving Lysocell, you would receive that in the outpatient setting, because we think that the risk of cytokine release syndrome is only 50% with Lysocell versus about 95% with Axicell, and the risk of neurological confusion is much higher with the Axicell than it is with the Lysocell. About 50% of patients who are receiving the Lysocell or Tisocell, in my experience, will not have fever, not require hospitalization. But once patients do have the problem of cytokine release syndrome and neurological toxicity, they need to be in the hospital and monitored by physicians who are, normally comfortable managing these situations. The non-relapse mortality in the first 30, 60 days is 1-2%. It's mostly infectious concerns in patients who've been heavily pretreated, and that's relatively low. The non-relapse mortality over the next 5 years is higher, and it's because of late in viral infections. COVID was a big impact on our patient population, but ongoing problems with RSV and influenza and other viral infections will persist in patients who've now been through many lines of chemotherapy, have no B cells while they're recovering their CAR T cell treatment, and have been through lymphodepleting, meaning they have low T cells. So our biggest concern managing patients after CAR T cell therapy is avoiding the infections. And if they do get sick, getting the patients back to the treatment centers, determining what the virus or the infection is, giving the appropriate therapy, and oftentimes giving intravenous gamma globulin, that's borrowed antibodies from blood donors, to keep your antibody protection, your B cell protection up, even if it's artificial from transfer of other healthy donors.
Thank you so much. Valeria has a question, so I'll unmute her.
Thank you. Thank you, doctor, for your class. It was really amazing to listening for a specialist. I have two questions. The first one is, there are some studies that show that axi-cel is better than tiso-cel because, in terms of efficacy and side effects. Can you tell us what do you think about that, please?
Sure. Okay, so you're trying to get me in trouble here, Valerie. That's okay. I appreciate this. It is important that we provide patients the most effective therapies and with the lowest amount of toxicity that they can manage. Axi-cel is a therapy that has been delivered successfully by Kite Gilead 95% or greater times. And some of the other therapies had difficulties, Novartis and Bristol Myers, in the early days of manufacturing products in a timely manner in specification that could then be released for patient use. And if you go through this whole process and don't have a drug at the end to treat the patient's going to do poorly, right? So having high success, short time manufacturing was the early advantage of Axi-cel. The product uses the CD28 co-stimulatory domain and has a more rapid expansion in the patient's body, which also may have benefits for some types of cancer. And Axi-cel continues to show a very high response rate in large cell lymphoma. However, expansion in the blood also associates with the toxicities of cytokine release syndrome and neurological confusion. And so those have higher rates of those toxicities as well when using the Axi-cel compared to tiso-cel or liso-cel. Now, tiso-cel, made by Novartis, was not successful in their randomized controlled trial for second-line therapy, and they are not FDA approved as a second-line therapy. Whether that's the trial design or the agent itself, I'll leave that for another discussion. Liso-cel was showing similar amounts of efficacy in second-line therapy, and most of us consider liso-cel, Axi-cel to have fairly equivalent benefits to patients. But again, Axi-cel is more rapidly produced. And there is hope, though, that that's going to improve since Bristol Myers Squibb just got an improvement in their release criteria with the FDA agreement over the last 1 month. So we expect that whereas in the past 25% of products were not in specification, not able to be used commercially, now we expect that number to go up similarly to what Kite has done in the past. So there's no simple answer to your question, Valerie, of which one's better. We need to match the therapy with the patient's need, but you will see institutional preference, and our institutional preference under my leadership has been the Axi-cel product. But that also means our patients are being treated in hospital with higher rates of toxicity that we then have to manage. And I look forward to moving patients out of the hospital for their therapies and being able to get the same benefits. And so what I always say is this is just round one of the car wars. There will be generation 2, which should be multi-targeting cars. There will be generation 3, which may be shorter manufacturing. And these clinical trials are being done at academic centers. So when you see your doctor says you can have the commercial or you can have the product on clinical trial, think long about having the clinical trial. Almost, the reason we're doing those clinical trials is because we believe they're going to be more effective. We have to prove that, of course, and our patients have to be our partners in those clinical trials that are bringing those new therapies forward. And as you know, the therapies we have today were brought to us by the patients who agreed to be on trials in the past. So, try to consider the benefits of clinical trials.
Thank you, doctor, for your honesty. And I'm sorry, I didn't mean to get you into trouble.
No, you're not. I'm not in trouble. This is my job. I'm the patient's advocate, okay? And we're working with the information that we have, and it evolves over time.
Okay, perfect. Thank you. And the other question that I have is about when managing DLBCL, what do you think about early prediction of cytokine release syndrome by measuring phosphate and magnesium?
I don't think it's necessary. I think that it turns out cytokine release syndrome is a manageable problem, and the observations of fever and CRP and ferritin as inflammatory markers have been easily interpreted. And with early intervention at fever plus low blood pressure, what we call grade 2 CRS, implement early anakinra and more use of steroids and less use of tocilizumab, have made significant advances in keeping patients out of the intensive care units and having a much less incidence of neurological toxicity as well. So I don't think that the magnesium phosphate is a big thing. I've spent a lot of time, actually money and time, my lab effort, trying to measure the CAR T cells in the blood as the predictor of what would cause the toxicity. But the problem is that it just happens too fast. And that exponential growth, 2, 4, 8, 16, 24, pretty soon it's 1,000, 4,000, 16,000. So if the cells peak on day 7, you don't really have meaningful measurements until day 5. And the window of who's going to get sick is just too short. So good questions, things to work on, but much more of a research question than a commercial care patient question.
Thank you very much, doctor. Thank you for your time and all your responses.
Yeah, no, thank you for joining us.
I do have one more question. Because you mentioned the process with insurance, do you find that CAR T therapy is usually covered by insurance, or is that a barrier?
So first of all, patients over the age of 65 have Medicare predominantly in the United States, and the median age of lymphoma, large cell lymphoma especially, is higher than 65. So most patients are on Medicare, which doesn't require an insurance authorization. The criteria are established, and the use of both liso-cel and axi-cel in second line is approved by CMS, and your physicians don't have anybody to ask. They literally should evaluate you and treat you. Now, in the situation where patients are younger on Blue Cross Blue Shield at commercial payers, then insurance authorization is frequently still required. And you will need to sometimes have your doctor appeal to this. But at my institution, I'm in California, and California is pretty progressive in these matters. We've never had a patient denied of CAR T cell, period. And in the early days when there were denials, there was a insurance appeal board in the state of California, and that solved that. So patients who are citizens of California, residents of California, Medi-Cal, Medicaid, undocumented, have received therapies with us that cost a lot of money, but save lives.
Well, that's great news. Thank you for sharing that.
Yeah.
We'll move on from questions now, and I'll just close. Before we go, I'd like to mention one of our very important programs called HealthTree Cure Hub. At HealthTree, we believe educated patients and researchers create better and faster cures, HealthTree Cure Hub empowers patients with the knowledge to actively participate in their health journey while providing research with valuable insights from real-world experience like yours. We invite you to join the 12,000 and counting blood cancer patients who are currently impacting their outcomes while accelerating research. Cure Hub is a one-stop platform that provides you the ability to connect to your surveys submitted by DLBCL experts, securely connect your medical records that track your disease within one single user-friendly interface, discover clinical trials, anonymously connect to your genetic twin matches, and lastly, gain access to a database of side effect solutions provided by other blood cancer patients. And you can enroll in that by clicking on the link in this slide. And as a reminder, our next webinar will take place May 30th at 1 p.m. Eastern Standard Time. That will be with registered dietitian Joan Elizondo will be our guest, and she will talk to us about dietary guidelines after cancer treatment. We will also have another live webinar on July 1st, 3 p.m. Eastern Standard Time, and Lolita Mahaldo will be sharing about palliative care. And you can join those by visiting the link at the bottom of this slide as well. And again, thank you to Dr. Miklos for joining us. Thank you for everyone who joined the webinar, and thank you to Regeneron and Bristol Myers Squibb for sponsoring this program.
Thank you.
For everyone for helping us build this community. Thank you. And you guys are free to go.
All right, Catherine, my pleasure. Thank you for organizing. Bye-bye.